Hello, everyone, and I'm really excited to have you guys with us today. As Kevin said, we are from Aldridge Pale, and we're going to be doing a series of trainings with you guys. Let me start by just talking a little bit about my background. So I am a mental health person. If I have any mental health peeps in the group today, go ahead and put that in the comment section. We've got kind of a smaller group today, so it'll be nice. I'll get to know you all a little bit. We are going to be talking about trauma for the next 2 days together. And what I think is really important for you guys to know is that we're not going to be talking about trauma and people with developmental disabilities as if it's some kind of a completely different beast. And I'm going to tell you guys a quick story about how I've come to think about trauma and developmental disabilities, dual diagnosis, and really that whole thing. So I have a private practice, and in my practice, I work a lot with trauma, but I also work a lot with grief and loss. I've done a lot of work with families with children with cancer and things like that. That's been sort of one track of my professional life. And up until about 10 years ago, I was also in mental health settings, became a mental health director, program supervisor, stuff like that. What you should know about the mental health agency side of my world is that if any of you guys out there today working with individuals with developmental disabilities had sent someone to one of my agencies and wanted to get, let's say, counseling for them, I would have turned you away. I wouldn't have done that because I was mean or, wanted to be a jerk. I would have done it because I would have told you and I would have believed that neither I nor the clinicians that I supervise had whatever the magic toolkit was that I assumed you needed to do with people with a developmental disability if you were going to do therapy. And I've been in private practice for almost 30 years. So I was in this mental health world, and I really knew nothing about developmental disabilities and assumed that it was this whole different thing. And then I got an opportunity to work at the state. I was sort of a liaison between the director of the Department of Mental Health and the director of the Department for Developmental Disabilities. My business partner, Kevin, ran policy in the DD world and invited me to come on sort of as a liaison between those two departments. So I was going to get a chance to learn about dual diagnosis in Ohio, which I knew zero about. And in fact, if any of you guys in the group today are mental health folks, you know that if you say dual diagnosis into mental health people, they will immediately think about mental illness and addiction. Developmental disabilities is way lower on the list for what we think about. It shouldn't be, because if you know anyone who works in a mental health setting, they'll tell you that folks who have some level of developmental disabilities, usually more in the mild range, are absolutely on our caseloads, and they tend to be our worst outcomes because we're generally not very familiar with developmental disabilities and don't do a great job of working with them, to be totally honest with you guys. So this was going to be a whole new world for me. This was back in 2009, and I got a chance to really learn about the dual diagnosis world. And I got to travel around to different counties, including Pickaway, and see dual diagnosis teams and what they were doing and how they were collaborating. And it was really exciting for me. And I got to meet really great people. And after a while, a couple of things happened. The first thing that happened was I would hear about all of these diagnoses that individuals or kids with DD would get. And, it's kind of the same things over and over, right? I would hear about ADHD. I would hear about bipolar disorder, sometimes schizophrenia. Let's see what else. Oppositional defiant in the kid world. We'll come back to that later. Borderline personality disorder, everyone's favorite. Occasionally schizophrenia or schizoaffective disorder, something like that. And I would hear these over and over. And what was striking to me was that I never heard PTSD. I didn't hear people talking about trauma at all. And if you work with trauma, and again, anybody with some mental health experience will maybe already have come across this. If you work with trauma, what you know is that trauma can look like different things at different times. If you get someone who's very shut down and disconnected and dissociated, they can look kind of schizophrenic or depressed. If they are agitated, triggered, screaming, they can look like they have bipolar disorder. They can look like they have attention problems. They can look like they have obsessive compulsive disorder. That was another big one. Kids who feel safe saying no, as a colleague of mine likes to say, look like they have an oppositional defiant disorder, whatever that is. And people who are used to lying and manipulating to get what they need to feel safe, high borderline personality. So in the mental health world, we've known for decades that people often will be misdiagnosed with some of these other things before trauma is identified correctly. In fact, it used to be true, I don't know if this is still true, but research a couple decades ago suggested that people with PTSD went through, on an average, 4 other misdiagnoses before they were diagnosed correctly with trauma. Now, hopefully that's gotten a little better in the past 20 years, but my guess is that things like that still happen pretty frequently. So we know this just in the general population, right? Just in the average person walking around, trauma can easily be misdiagnosed. I think that's true for other groups even more so, which we will also talk about in a little bit. So here I was traveling around Ohio, meeting these great professionals and really dedicated people, talking a lot about dual diagnoses and mental illness, but trauma was just never mentioned. And that's when I realized that in the DD world, we were a little behind, that trauma was simply not on people's radar at that time. And along with a number of other really cool people, I got to be a part of bringing broad, large-scale trainings to Ohio and helping the departments to fund that for professionals and for DSPs and folks in the school system. That has absolutely continued over the past 10 years. And now, as Kevin and I work with people around the country and in Ohio, trauma is at the forefront of people's conversations. So I'm really excited to have gotten to see this transition over the past 10 years. And really excited that we're able to do this with you guys today. I'm really excited that I'm going to get to know this little group of folks, and then we're doing this again, I think next week or in a couple of weeks. So there has been a really big change in the awareness of trauma, or folks being trauma informed. What I've learned also about trauma has to do with that same time back in 2009, 2010. As I said, I was traveling around the state and getting to see what people were doing. And I had the opportunity to go to, not Pickaway, in a different region of the state, where a psychotherapist, just like me in private practice, was building a practice of working with people with developmental disabilities. Not exclusively, but she worked with a lot of folks with DD. And that was really rare back then. Unfortunately, it's still pretty rare now. And she, because of this, was working with her local county boards to create materials that other clinicians could learn from. And she was taping sessions, with permission, of course, as kind of this opportunity for learning and training for mental health folks. Well, as you remember, back in my mental health life, I assumed that psychotherapy would look really different with someone who had a disability. So I was very excited, because here was the magic toolkit. She'd, sent away to Hogwarts and gotten all the magic spells for how she was going to do therapy with someone with a developmental disability. And I was going to watch the tapes of these sessions, and I was going to get to see it. So we won't go into a lot of detail because I don't have nearly as much time with you guys as I would like, but let me give you just the outlines of this man's story. He was in his, I think, early 40s. We'll call him Andrew. And Andrew had lived all his life with his mom and his dad. And then within a year, first his mother and then his father had gotten sick and passed away. So he had moved to a group home, again, for the first time in his life ever living anywhere but his home. And he was very lucky in a number of ways that I think I didn't fully appreciate at the time, and I have a better sense of now that I've been in this field a little while. He went to a good group home. It was well run. It had caring staff. Most of the staff there had been there for a while, for several years at least, which is a big deal in our field with the turnover that we're dealing with. And worked well together, had a pretty good team going. So things worked out well for Andrew. And he moved into this group home, and it wasn't really a problem for people. He didn't have disruptive things that he did or anything like that, but he just seemed sad and didn't seem to really be connecting or engaging with anyone. And this is where the story really takes a turn, which again, at the time I didn't appreciate. What was very unusual for him was that someone suggested that Andrew might want to talk to someone. And as you guys know, that's pretty rare in DD for that to be the first thought that someone has. If you have a developmental disability and you seem to not be getting along well or handling things well, or you seem to be struggling, the first thing that people think of, and unfortunately often the last thing people think of, is medication. Now, I'll full disclosure, my dad is a pharmacist. I am drugs, check plus, yay, drugs. I am not anti-medication at all. Sometimes the right medication at the right dose for the right person can be life-saving when it comes to mental illness. But I will also say that for most of us walking around, that's not the only thing someone ever thinks of for us. If I'm having a hard time in my life, people usually think of a range of things, including wellness and fitness and connection and my spiritual life and psychotherapy, and maybe also meds, but they all fit together as a puzzle. If I have a developmental disability, medication is usually the first and only thing people think of. And if that doesn't seem to be helping, let's just get more medication, right? So we have an over-medication problem in our field. Remarkably, people decided they wanted to start with talking to a therapist. So he went to this therapist, was taping the sessions with his permission. And now you're all caught up, and I'm going to watch the session for the first time, right? So I'm watching this and I'm thinking, what on earth is he going to talk about? Does he want to talk about having a disability? How could you work on that in therapy? That's not something you can fix or change. And if you guys were all in the room with me right now, I would ask you these questions and you would get them all right. 100%. This has never failed with any audience I've ever done this with. Remember Andrew's situation. What do you think he wanted to talk about when he got a chance to talk with a therapist? Well, he wanted to talk about different things on different days, but for the most part, what he wanted to talk about was losing mom and dad, missing them. He wanted to talk about how sad he was. He couldn't really sit still for a 50 or 60 minute traditional psychotherapy session. He could do 20 or 30 minutes. So how long do you think the sessions were? 20 to 30 minutes. Often as a therapist, I ask clients to keep a journal for their thoughts and feelings between sessions, but Andrew couldn't read or write. So what do you guys think maybe the therapist had him do? Yep, he drew pictures of his feelings or memories that he had of things he did with his mom or with his dad. Sometimes he would also talk with a staff person and record it and bring it in. So you guys get the point. What I thought was going to be a session about developmental disabilities was a session about grief. Remember, that's another part of my life, another part of my practice. And so as I sat there watching these tapes, I suddenly had this revelation. This is a grief and loss session. I know how to do this session. There were some common sense modifications. I could go into more detail, but things that any sensitive therapist would have been able to figure out. And of course, he had this really supportive team of people around him that were also there to help figure out how can we modify things to make sense for Andrew, which is what a good therapist does anyway. So that was really those two experiences, getting into the DD world and hearing that trauma was something that people weren't familiar enough to know that some of these diagnoses people were getting were probably incorrect. And then the second half of this, the experience of watching this session that I thought was going to be some special, different, foreign thing to me that was really about grief, really helped me understand that the cliche that we sometimes say to each other is really true. We are far more like each other than we are different. Grief is grief. A broken heart is a broken heart. And there are some differences in how to communicate that or how to support that, because Andrew's brain processes things a little bit differently, but really, they're the same. In fact, he said something that stayed with me forever after. At one point, he said, I feel like my heart is broken inside my body. If you've ever lost somebody important to you, I can't think of a better way to describe grieving. And executive functioning, or processing, or what, that really doesn't make any difference. And as we spend time together, we're going to learn that a scared brain is a scared brain. There are only so many things your brain and body can do if you perceive that you are in danger. There are lots of ways that you can be misunderstood if you have a developmental disability. There are lots of ways in which people aren't maybe equipped to support you properly. But again, trauma really doesn't seem to be different based on someone's level of functioning or IQ or any of those things. We need a lot more research into trauma and people with developmental disabilities. And the incidence of trauma, the vulnerability to events or circumstances that can cause trauma for someone. We'll talk about the ways that developmental disabilities might confuse other people for what's going on. But we're not going to talk about trauma and DD as if it's some different thing. Those of you who've had trauma-informed care training will recognize the basic principles of trauma. And I always say that having a trauma-informed care background is really important. You have to be informed about trauma and know about trauma. We created trauma-responsive care to be what you do next, the next step after being informed. Those of you who've had no trauma training whatsoever, we will still cover kind of the basics of trauma, so we'll all end up in the same place. We're going to spend most of the day that we have together today, these next 2 hours, talking about what's going on in the brain, what's going on in the body when someone is exposed to traumatic levels of stress. Starting tomorrow, we will switch gears and talk about trauma responsive care. How do we approach people who may have experienced trauma to be the most helpful and the most responsive to them? And then we'll talk about the calmer skills, which is something that we created just to give people a place to start with how to approach various situations with someone who may have experienced traumatic stress. So with that introduction, I'm going to go ahead and share my screen, and we are going to talk about trauma. So everybody say a little quick silent prayer that this actually works, because I'm not the greatest at technology, but I think we've got this. Yay, hopefully everybody can see that. And we will be taking a break around 10. We'll take a 10-minute break to give everybody a chance to move around. And as Kevin mentioned also, if you have questions or comments, or you want to share your experience in the field or whatever, I always find that incredibly helpful. So please feel free to put it in the comments section, and I will be checking that periodically, and we'll do that over the break as well. All right, so let's get into this. I love starting with a few quotes. So we're going to start again, just to sort of set the stage for how I think about trauma and how we'll be talking about it together over the next couple of days. So this first one, I want to explain who this is. Tamsin Cottis is a psychotherapist in England, and in London, she opened a mental health clinic just for people with dual diagnosis, with some form of mental illness and a developmental disability. And this is what she said in the book that she wrote about this in terms of trauma. It is worth noting at this point that many patients referred to her clinic seem to have become disabled more by their traumatic life experience than by any congenital impairment. This is, it's a short quote, but it's so radical that I want us to take a second and really absorb this. What she's saying is that when folks are referred to her clinic because they're struggling, trauma is more the immediate barrier that they're working with than whatever developmental disability they have. So imagine this for a second. Imagine that in Pickaway County, I'm an individual that you're going to work with, or a student in your classroom, whatever, someone coming newly into your system. And the most important thing for you to learn about me, the first thing you're going to learn about when someone hands you my file or whatever it is my trauma history, is how I feel safe around people, what makes me not feel safe around people. And all the other stuff, that I have Fragile X or that I'm on the autism spectrum or whatever that might be, that's important too, whatever assessments have been done. I'm not saying that that's not relevant, but that is secondary to knowing what I've experienced around other people or how I seem to react to other people. That's the first thing you learn about me. That would be a complete reversal in many ways of how our system is set up now statewide and mostly nationally too. So moving on to the second one, we'll talk, as I said, I'll get to know you guys a little bit over the next 2 days. If any of you have an interest in trauma, you've done trauma trainings or your own reading, then this next name will probably be familiar to you. Bessel van der Kolk is, I would say, the most recognized name in trauma around the world. He's written best-selling books for the general population to understand what we know at this point about trauma, where we're going in terms of trauma research and trauma treatment. In fact, when I taught trauma at the College of Social Work for graduate students at Ohio State, I used his books as one of my textbooks. So if you're interested in further reading, he is where I would recommend that you start. And again, I'd be happy to talk with you guys more about that. So this is what van der Kolk said. He actually said this at a training that I attended. In fact, the past is the past, and the only thing that matters is what happens right now. And what is trauma is the residue that a past event leaves in your own sensory experiences in your body. And it's not that event out there that becomes intolerable, but the physical sensations with which you live that become intolerable. And you will do anything to make them go away. And there's a lot happening in this paragraph, so I want to break it down a little bit. The first thing he says is that one of the things that people fundamentally misunderstand about trauma is this idea that, well, all of that just happened in the past and you just need to let it go, right? I will not sing Let It Go for you guys today. If you're parents, you already know this song very well. If you've ever worked with people dealing with trauma, if you've had people in your personal life dealing with trauma, if you yourself have dealt with it, you're probably familiar with this idea that people will say, you just need to stop thinking about it. You just need to stop dwelling on it. You just need closure. And, you know, for people living with trauma, that's sort of like, oh, I should just stop thinking about it? That's a great idea. I wish I'd thought of that myself. The issue with trauma is that it is reoccurring now. And if there's one thing that I think you guys can be incredibly helpful with, it is helping to clear up this misconception with the individuals you're working with or the student in your classroom, whatever. When you're talking with frustrated staff, frustrated family members, frustrated teachers or bosses at a work setting, whatever it is, helping them to understand that it's not perseverating, it's not dwelling, that when someone is living with trauma, if they are experiencing that trauma intruding into their present life, it is absolutely happening right now. So let me tell you guys the story that I have told now to probably thousands of people around the world, really. And this story was first told to me by my professor when I was in college. So when my professor was a young man, the Vietnam War was going on, and he was a farm boy from Ohio, not far away from Pickaway County, and he volunteered to go fight in Vietnam. And he was assigned to be a medic. So what that meant was that a call would come over the radio, and they would fly out to where hopefully fighting had stopped. They were sometimes flying through this really thick jungle canopy. So if a rotor hit one of those massive trees, it could break and they would all crash and die. So they tried not to do that. They landed where theoretically the fighting had stopped, but a lot of times they were also dodging fire. They would run to where the soldiers were, grab them, I will not describe to you what he told us about what sometimes happened when they did that. Get the soldiers onto the helicopter as quickly as possible, take off, fight desperately to keep them alive while they flew them to a medical base. Needless to say, many soldiers did not survive that flight. And I will absolutely not describe to you what he said the inside of that helicopter was like on that flight back. So this was his job every day for a year. And then he went home and he finished his education. He became a therapist and eventually a professor and married a nice lady. And one day he and his wife went to the movies here in Columbus. And the movie that they went to see was called The Deer Hunter. And that may not be a title that's familiar to you. Some of you may know that film. It was one of the first very realistic, very graphic movies about the Vietnam War. And what my professor told generations of his students after was that he can't tell you what was on the screen. That information was not available to him. What he knew was that 1 minute he was sitting in the movie theater with his wife, a professor and a therapist. The next thing he knew, he was crouched in the movie theater aisle screaming, incoming, while his wife and an usher were dragging him out of the theater. Now, you guys didn't know my professor who passed away about 15 years ago. So you'll have to take my word for it when I tell you that he did not decide to do that. Why do I mention that? Because I want you guys to take that same story, and we're all just going to be really honest with each other for a second. I want you to imagine that instead of a PhD and professor, he was an individual with a developmental disability, and he had gone out with the other folks in his group home, or he was a teenager in a special ed classroom, and they'd gone out and they'd gone to the movies, and had at some point he had leapt out of his chair and crouched down in the aisle and was screaming and had to be dragged out of the theater. What would happen to that individual when they got home that night? What would they be told? We can be honest, right? They would be told, well, you're not going to the movies again anytime soon. And why? Because of your poor choices or because of your behaviors. What happened to my professor in those few seconds was far closer neurologically, if you look at the brain and body connection, was far closer to a seizure than it was to a behavior. Because I define behavior as something that someone does on purpose. So if I lift up my coffee cup, I'm doing that to drink the coffee because I want coffee, because I'm a terrible coffee addict. And I want my brain to be able to function with you guys this morning. If I were doing this training with you and I suddenly collapsed to the ground with a grand mal seizure and I was convulsing, none of you would think, wow, what a strange choice she's making right now. I wonder why she's behaving in this odd way. You would understand that what was happening to me was out of my control. But when someone has a developmental disability, we look at that and tend to assume that it's something they're doing on purpose, that they do have control. And I get it. Right? I have to be honest with you guys. If I were sitting in a movie theater and some guy jumped up and started screaming, I would probably think what you would think. I would think, that guy must be crazy, right? That's what I would think. If we don't know what's going on with someone, and especially if they are non-speaking, especially if verbal communication is difficult, then it's really hard not to look at that and think they're either completely nuts or they're doing it to cause a ruckus, to get attention or whatever. Let's use a different example. Let's say that it's my first day at work. Okay, I'm a new staff person, and I go up to Kevin, and he's had bad treatment at the hands of little tiny dark-haired women with glasses. So he takes one look at me, punches me in the mouth. He's going to be in a lot of trouble, right? And he's going to have a behavior plan, and he's going to have this and that. He might lose where he lives and have to be moved to another place or another county or whatever. And really, if we had had the opportunity to understand more about what was going on with him, what we might find out was that he was terrified, and punching me to make me go away was the only thing that he knew how to do to deal with that level of terror. And that's what gets us to the next thing that van der Kolk talks about. Trauma is the residue that a past event leaves in your sensory experiences in your body. So, for example, if someone has a flashback, like what happened to my professor in the movie theater, he wasn't thinking about the war. He wasn't remembering the war. His body was reacting to the war. And it was much closer to a reflex, like when a doctor hits your knee and your leg flies up. And in brain terms, it's about, some people have estimated, half a second faster, which doesn't sound like a lot of time, but in brain time, that's a very slow catching up that your brain does, right? So his body reacted to whatever, the explosion or whatever it was on the screen, and leapt up, and he started screaming long before his thinking brain could catch up and go, oh, wait a minute, I'm not in the war anymore, I'm in a movie theater. So imagine the level of terror and horror that it would take for your brain to make you jump out of a chair and start screaming. And what would you be willing to do to not feel that, to block that out, or to prevent yourself from experiencing that? Well, I'll tell you what I would be willing to do. In the right set of circumstances, I would overeat, I would starve myself, I would drink, I would use drugs, I would, compulsively shop or compulsively gamble. I would cut myself or bang my head. I would have sex with inappropriate people. I would do whatever I needed to do to make that level of terror and horror stop. And so would you. When I was in that training, van der Kolk looked out into the audience and said, you will do anything to make them go away. And in some ways, I think that's the most important word in this whole important paragraph. He didn't say, if you have a disability, or if you're some messed up vet, or if you've got problems. In the right set of circumstances, if we don't have any other options that we feel are available to us, we will do whatever we need to do to make that level of terror stop. And now, Kevin punching me in the face suddenly makes more sense, right? If that's what he needed to do to get away from me, to feel safe again, if he was triggered in his trauma, yeah. I'm not saying that makes it okay, or that we don't work with Kevin to help him feel safe in different ways so that he's not, hitting people. I'm just saying it really makes us put that in a completely different context when we think about the level of fear that it would take for someone to do that, and the fact that in the right set of circumstances, we might do exactly the same thing. I can assure you my professor did not choose to terrify his wife and humiliate himself in a room full of strangers. So the fact that after doing this training and whatever other learning you're doing in trauma, you will perhaps be able to be the person who can help other folks understand that what happens when an individual experiences a flashback or lashes out or whatever is not a choice that they're making. It's not behavior in the way that we usually use that word. And finally, we'll get to the last quote, which, although it's the simplest, I think is in some ways the most important on this whole slide. So Pierre Genet was a, excuse me, a 19th century French neurologist. He and some of the work of other people like Charcot really set the stage for things that people like Freud and the psychotherapists of the 20th century were able to do. So he was one of the early brain scientists. And in talking about trauma, what he said was, trauma is a disease of not being able to be here. And in some ways, I think this is the most important thing on this whole slide, because the real tragedy of trauma is when it keeps someone from being in their own life. If Kevin is triggered by a little dark-haired woman with glasses and punches me, he's not actually responding appropriately, right? Like, I am not dealing with severe chronic levels of trauma often find their worlds getting smaller and smaller and smaller and smaller and smaller. And they don't actually get to be in their own life. So when it comes right down to it, the reason that I'm so profoundly grateful that I get to spend this time with you guys over the next 2 days is that you may very well be that pivotal key person who helps unlock some of what might be going on with someone and give them the opportunity to actually be present in their own lives. I can't think of anything more important. So let's go ahead and jump into some more stuff. We're not going to spend a ton of time on like definitions. I'm going to go over some things briefly. I'll talk a little bit about, when someone's diagnosed with PTSD, what does that diagnosis look like, all of that stuff. So we'll cover that briefly. And again, if you have questions, if I'm going too fast over something, or you want to add or share something, please go ahead and jump into the comment section, and I will be checking that a couple of different times today. So really, the simplest way to talk about trauma is that trauma is something that makes you feel that you might be about to die, or that you could be emotionally overwhelmed with terror and stress. So if I were driving on, let's say, 270, and my car flips over and it goes rolling into the ditch, and I'm trapped in there and I can't get out, and it takes hours to cut me out, and I'm thinking that at any moment the car might catch fire, might I think that I'm about to die in that moment? Yes, absolutely. Might I have some elements of PTSD, or even have a diagnosis of PTSD after that experience? Yes. That one's really easy. And we tend to think that whatever happens to someone's body, if I go through that, or if I'm sexually assaulted or something like that, that, it's a pretty quick jump for us to go, oh, yes, that might cause trauma. We don't think about it quite as quickly when we're talking about other kinds of trauma. But let me give you an example. Let's say that instead of being this age and being in a car, I'm 4 years old, and I live in a home where there's a lot of domestic violence. There's a lot of screaming and hitting and throwing things, and the police showing up and all of that. But for whatever reason, I myself am never physically hurt. No one harms me physically. But I'm watching all of this happen. I'm hearing it at night in my room, which is actually in some ways probably worse than seeing it. Might I be emotionally overwhelmed with terror and stress? Yes. In fact, some studies suggest that if you do brain scans of a soldier who's been in combat, and a child who's experienced some form of abuse, and let's say, I think in one study it was sexual abuse, and a woman who'd been in an emotionally domestically violent relationship for, I think, 20 or 30 years, the brain changes that we can see with those intense levels of trauma are identical. There are only so many ways that we can try to cope with overwhelming levels of fear and stress. This is so important because if I'm an individual and I come to your group home, or I come to your county, or whatever it is, and someone tells you that I have experienced chronic physical abuse or sexual assault, I think we are quicker now, certainly more than, let's say, 10 or 15 years ago, to think, oh, Laura might have some problems with trauma. But if I'm, let's say, a young person in your classroom, and I've been chronically bullied or humiliated, but no one's laid a finger on me, we are less likely. It's not impossible, and I think it's becoming more and more common. It's more and more on people's radar, which is so important. But still, there are plenty of times where people are going to look at me and say, well, at least she wasn't abused. Emotional abuse, verbal abuse, travels possibly on the same pathways as if someone is hitting me. The way we experience pain, for example, we think pain is in the body. If someone, breaks my wrist, where does it hurt? It hurts in my wrist. This is where the pain is. But we know that actually pain is in my brain. That's where it's controlled. And there is research that's been out for a while now that suggests that the pathway that signal travels on to tell me that there's pain, that it's the same in my brain, whether it's physical pain or emotional pain. The same cells are lit up, the same pathways traveled. So that means that your brain really doesn't distinguish between the pain of someone twisting your wrist and the pain of someone humiliating you or bullying you. So the reason I spend time on this is that this is an area where I feel like DD, we're still catching up a little bit to recognize that trauma can be any of these things. It doesn't have to just involve the body. And van der Kolk, again, says it really nicely when he says, an experience becomes traumatic when the human organism becomes overwhelmed and reacts with helplessness and paralysis. This is also important. If I can do something about a stressful situation, I may not experience it as traumatic as if I'm trapped. So take that same car accident. Okay, I'm rolled into the ditch, but this time I'm able to unbuckle my seatbelt, which I was wearing, right? And I can crawl away from the car. Now, I may still experience that as a traumatic event, but the fact that I was able to pretty quickly move and get out of it and do something to get myself safe, something for my own benefit, I may be much less likely to have residual effects of PTSD as if I were trapped. Why do we care about this? How often are individuals in our system in settings or situations that they can't easily leave? Now, that obviously can also be true of people without developmental disabilities. So, for example, in a relationship with a lot of emotional or physical violence, there may be many reasons why someone feels that they can't leave. If any of you are in the kid world, you see exactly the same thing. Kids can't say, oh, I'm sorry, this family isn't working out for me. I'm going to go on Craigslist and see if I can't find a different one. So certainly we're not saying that only people with developmental disabilities experience that feeling of, I'm stuck here, I'm trapped with this. But I would argue that it's part of why we do see higher levels of trauma in people with developmental disabilities, because if a staff person is bullying them, or their roommate is mean to them or scary, or someone is exploiting them or victimizing them, we don't always know about it, we don't always see it, and they may very well feel much more stuck because they are often, not always, but often. So, this one we've already sort of talked about. If you can move, if you can do something, you may not experience the same levels of traumatic stress. When we are in a terrifying situation, our bodies and brains are flooded with stress chemicals. We will be talking in more detail about that later. And that may be actually damaging to the brain. If our brain is exposed to too many of those stress hormones for too long, it may actually contribute to the brain change that we can see in some people when they have especially early, severe, and chronic stress. Okay, so some of these things we've already touched on, and this slide I feel like people usually already have a decent handle on. Sometimes trauma therapists will talk about big T or capital T trauma. And we mean that to mean an event that potentially only has to happen once to be life disrupting. So it is a huge catastrophic event or series of events: sexual assault, physical assault, verbal or emotional abuse or manipulation, war, living through a natural or a man-made disaster, some really invasive, painful medical procedures or catastrophic, life-threatening illness, traumatic grief, humiliation and bullying, deprivation and powerlessness to act on one's own behalf. Remember that? I have a friend and colleague who works with different states around the country, working with people who've either been incarcerated or hospitalized for decades. And this is not a slam at any of those institutions. I think many of them try to be humane and care for the individuals in their care. But if you live somewhere where the door's locked and you're not allowed to leave, that can do a number on your brain over time. We know that. So these are the things that, again, we call big T trauma, capital T trauma. You only need to experience it once to potentially have some issues. I won't go into a lot of this, but some of this just in case you're interested. Obviously, there are some factors that may make a situation more likely to be traumatizing. And these are pretty common sense. How long did it last? How intense was it? Time of day. Here's a fun fact. If someone is mugged, let's say in a parking lot at noon versus midnight, we tend to see more levels of trauma in someone who is mugged. Anyone want to guess? That's right, at night. And we think it's because even though the assault may have gone exactly the same way, having some sense of, oh, I knew where I was, I could see what was around me, I could maybe see this person coming at me, having some small feeling of control, even if it really didn't affect the outcome, helps people more than when they feel completely blindsided by something. We also know, and this is interesting for folks who work in resilience projects, that there are some inherent factors that may help buffer people or that may make them more vulnerable to trauma. The one that I really want to talk about here is the previous history of trauma. Now, if you think about it, that sort of just makes common sense, right? If I've experienced high levels of stress already, it may not take much more stress to make my brain go like, oh, and I start to really experience some of those problems with flashbacks or shutting down or dissociating or whatever it is. However, it's important to remember that, and this is true for all mental health diagnoses, but especially with trauma, people are not always diagnosed the same based on how they look or how someone doing the diagnosing feels about them. For example, I worked many years with teenagers in different settings. I love teenagers. I think that teenagers are the pineapple on pizza of people. You either really like it or it is just not for you. Teenagers divide people very quickly. So if any of you out there work with teens, you're a teen person, you know exactly what I'm talking about. So I really enjoyed working with teenagers. It was a lot of fun. I once had the experience of doing some contract supervision for an agency that was between clinical directors. Why this matters is that if folks have like an LSW or something like that, they can't diagnose someone by themselves. They have to have someone with a higher license sign off on it. And there was a big backlog. There were like 200 files that they needed someone with a higher license to go through, read the assessment, read the diagnoses, and then sign off on it. So they just hired me to come in a few hours a week to go through and deal with this backlog of cases. Okay, so I had the chance to watch how this played out in about 200 kids. What I saw, and this lines up with lots and lots of research that we have about this, is that girls were more likely to be given emotional diagnoses than boys, sometimes with very similar presentations and very similar histories, right? And I think part of that is because that girls may be seen as less threatening. They may be seen as vulnerable. We tend to look at them as sad. When boys are dealing with emotional upset, we tend to see them in terms of the behavior that they're exhibiting that may be causing disruption, and we see them as bad. Girls look sad, boys look bad. This is especially true for boys of color. And going through these files, I saw young Black man after young Black man, 12 to 17, growing up in situations with violence or family disruption or catastrophic traumatic loss or whatever it is, basically a factory for trauma. And the number of those boys who had a PTSD diagnosis, even as a possibility. Does anyone want to guess the number? 0. Not one. Not one kid. So we don't just deal with problems like over-medication in our field. We also deal with problems like mental health diagnoses absolutely can be affected by things like gender and race. And we have a problem with that. We need to see all of the individuals that we serve as potentially vulnerable. But if we see the person sitting across from us as potentially scary or threatening or problematic, we tend to give them those behavioral diagnoses. What I would see over and over for those Black boys were oppositional defiance, which is the dumbest diagnosis ever. I think it's a really badly designed diagnosis. Sorry if you love it. We can talk if you want. And then that would go to conduct disorder. And anybody in the mental health world can tell you that conduct disorder is what you give teenagers because you can't diagnose them with antisocial personality disorder until they turn 18. And antisocial personality disorder basically means criminal. Now, I am not here to tell you, oh, ADHD, that was the other one. ADHD, oppositional defiant conduct disorder, and then antisocial once they turned 18. Criminal. Now, I'm not here to tell you that none of those kids also struggled with ADHD. I think some of them did, absolutely. I think ODD is a really dumb diagnosis and it doesn't mean very much of anything. What I know from research and my own clinical experience is that when you get kids who have been diagnosed with something like conduct disorder, or if you work in the prison population with people who've been diagnosed antisocial personality disorder, and you start looking at their trauma history and you treat them for trauma, suddenly these symptoms of antisocial personality start to resolve. Because one of the things that trauma does, and we'll talk about this, well, this is where we'll pick up when we come back from the break. One of the things that trauma does is it shuts down your feelings. It shuts down your feelings inside you, and that means that it's impossible to feel the feelings of other people. So that lack of empathy that we see, what that might actually be is someone who is in shutdown most of the time from their own feelings. Now, I'm not here to say that some of the folks who are in prison don't belong in prison. Some of them absolutely do. And I'm not saying that trauma is the only issue that someone might be dealing with, but we know from the general population that the differences in race and gender, just to name a couple of things, make it likely that we are missing people for trauma. And we are labeling them with things that may be inaccurate or completely incorrect. And it's really important to me that we understand this going forward and that this is something that is on your radar. I don't want it to mean that you question every diagnosis you ever see from now on, but you do need to remember that diagnoses are made by people, and people are flawed and people are fallible. And just because something is written in someone's file doesn't make it gospel truth. And if we can bring that awareness, then I think we can see people more accurately than perhaps they've been seen in the past. So with that, we're going to pause here. So I'm going to pause the share here for a second. We are going to take our break. Again, we'll take a 10-minute break. So I'll see you guys in a minute.